After ensuring BSI and seam safety, you can begin assessing the patient and making a general impression. Look for any signs of trauma to the patient and determine if C-spine precautions are needed. Begin to assess the patient's airway, breathing, and circulation. Be prepared to intervene if any issues should arise with the patient's ABCs. If you have an issue with airway, first use manual maneuvers like a jaw thrust or chin lift. Then you may want to place an NPA, OPA, or advanced airway, demonstrated in the clips shown here. If you have an issue with breathing, it's best to place the patient on oxygen. This can be done with a nasal cannula on low flow, or by non-rebreather and BVM on high flow. If you have an issue with circulation, you can make attempts to correct the issue. Issues with circulation could be the underlying cause in altered mental status or syncope patients. Have your partner place the patient on the monitor and obtain a full set of vitals, including a blood sugar check. The paramedic may treat the patient's heart rhythm if appropriate. If the patient is suspected of a possible narcotic overdose, 2 mg Narcan can be administered to the patient via IN. This dose may be repeated once in 5 minutes if respiratory depression persists. One milligram of Narcan may be administered intramuscular if unable to administer the medication IN. Try to obtain intravascular access for any possible medications the patient may need to receive. This may be deferred if Narcan returns the patient to their normal mental status. Here you will see the application of fluids for the patient. Protocol 530.18 allows for the administration of LR at a TKO rate. After 10 minutes, 1 mg of Narcan can be given slow IV push after no response to IN or IM. At this point during your call, your partner has likely been able to obtain your first set of vitals and blood glucose level. If the patient's BGL is below 80, dextrose may be given through the patient's IV. Be cautious of infiltration when administering dextrose to your patient because infiltration may cause tissue necrosis. If IV access cannot be obtained, 1 mg of glucagon can be administered intramuscularly to raise the patient's VGL. Transport stat if the patient is unstable and minimize on-scene time. Make contact with the receiving hospital if appropriate as per Protocol 530.02. Ensuring BSI and scene safety, you can form a general impression and assess the patient's ABCs. Assess for poor perfusion or respiratory distress. They may demonstrate one or more of the following: delayed cap refill, diminished distal pulses, cool extremities, or altered level of consciousness. Apply 100% oxygen with blow-by or BVM for 30 seconds. If bradycardia persists, initiate CPR. Here you can see further inspection of the airway. Pediatric small airways are easily obstructed. Look for any foreign bodies that may need to be removed. The patient's pulse rate had not improved with ventilation and oxygenation, and CPR was initiated. Secure your patient's airway if indicated with manual maneuvers, OPA or NPA placement. Obtain intravenous or IO access. IO access is the preferred method for infants if patient is under 3 years old and has symptomatic bradycardia. Begin transport and prepare to administer epi and atropine. Attempt a fluid challenge at 20 ml per kilogram if there is no response to medications. TCP may be considered if there's a delay in obtaining intravascular access but requires base contact. Epi will be administered at 0.01 mg per kilogram every 3 to 5 minutes. Atropine may be given at 0.02 mg per kilogram with a minimum of 0.1 mg and max single dose of half a milligram, and may be repeated once. Transport stat if the patient is unstable and minimize on-scene time. Make contact with the receiving hospital if appropriate as per Protocol 530.02.